This conference will now be recorded.
Welcome everybody to the third Q&A update for the COVID protocol. I'm going to try to get my echo to go right. If you are not speaking, if you would please mute your own mic. Try not to have to mute everybody. Miss questions. All right, Dr. Brand, are you online?
I'd be here.
All right, I'm getting a lot of echo. So I'm going to have to mute everybody and. All right, I think we are online now. There we go. All right, I had to mute all the lines. I will unmute those when it's time for questions. So I was getting a lot of feedback from my own mic. So we're here to talk about the updates to the protocol, some of the revisions. And Dr. Brandon just sent you an unmute request. You should be able to click that to.
That's the first time in my life anyone's ever unmuted me.
So I'm gonna, I thought I'd start with just kind of showing the website for those who are online looking at the screen. I've got the flow chart up on the screen now, and then we also have a link to the actual protocol document. So the protocol is in a PDF format, and I would just encourage people to not download the PDF copy and just save that document, but to save the link to the document on your phone. And I'll put on some instructions this week to show you how to do that on the various mobile devices. But if these are saved in a Google Doc format, so if you have the link saved to your device, you'll be able to always have the latest documents. And I'll also show how to set that as so it's available offline, which will keep the device accessible even if you don't have internet access. But as we all know, the science on COVID-19 is changing on a regular basis. Sometimes daily, and so we'll be making protocol changes probably not that frequently, but certainly frequently we do expect to see at least some minor changes. But we have the flow chart here that should be a summary document, and that's designed to be used in conjunction with the larger protocol document. It doesn't have all of the details in it, but should serve as an effective quick reference for you. So I'll turn it over to Dr. Brand to go over some of the highlights of the new protocol, some of the changes that we made here, and give any science updates you want to give, and then we'll open up for questions and answers.
All right, well, I think I'll hit the big highlights of this COVID response just from a global perspective, and then we can kind of march through the details and talk about the details a little bit going forward. Basically, I've been spending my time, and several of us have been, listening to webinars put on by the federal government and others about how to, basically that are putting doctors, nurses, paramedics online who are taking care of COVID patients real time. So, you know, I've taken care of exactly one COVID positive patient who's a friend of mine. And so I am no expert by any stretch. But in lieu of that, what I've tried to do is learn from other healthcare providers that are taking care of COVID patients to try to learn the lessons that they're learning real time to bring them to our region and share them via protocols and advice. So my favorite saying during this entire thing is that taking care of these patients and building EMS protocols for this crisis is kind of like building an airplane while you're flying it, because it feels exactly like that. There are already 3 or 4 revisions to this protocol that I think we're going to need to make in the next week, and we just rolled it out today. So that's just the way it's going to be moving forward for a little while until we have some real science on what's going on. So there are a couple big picture principles that I think everybody needs to get. The first is when we're doing EMS operations, everybody is a potentially infective person. Okay, period. If anyone you come into contact with, and that includes your coworker, is potentially infected, because we know this disease can spread from asymptomatic people to people who are healthy and cause illness. There's no question about that. So the it's important that all of our activities, all of the activities in the firehouse, the rescue squad, in the back of the ambulance, in the ER, every activity, every interaction we have needs to be predicated upon the probability that the person we're dealing with could potentially infect you. So that means that PPE is in place all the time on a call, all the time in the ER, and possibly in when you're on duty. The other big picture and then after that, you have to basically stratify yourself. Do I need to do positive protective equipment for ordinary risk, meaning just everybody has it and they're trying to give it to me? Or do I need to do extra special protection? The extra special protection would be when we're going to be close to somebody's airway, dealing with somebody's saliva, possible aerosols, somebody who is known to have COVID infection or is highly likely to have COVID infection, because it only makes sense to think that those people have more virus that they're spreading around. And there's reason to believe that the more virus you're exposed to, the more likely you are to get sick and the more likely you are to die. So if we're doing procedures, intubation, airway maneuvers, somebody who's coughing, somebody who's sick, has a viral syndrome, we need to be doing airborne precautions, mask on the patient, N95 on yourself, face shield, gown, gloves, ventilator, the air vent on in the ambulance, which creates a negative pressure environment, and be super cautious, right? But then we can't let our guard down when it comes to a patient who's, a 6-year-old girl who's fallen and broken her leg riding a bicycle in her backyard. She can give you COVID too. So in that case, it's not as likely. So it's going to be, it doesn't need to be an N95. There doesn't need to be a face shield, but there needs to be gloves. And we need to decontaminate everybody's hands, and we need to be very careful about interacting with everybody on a basic level. So I think that's the primary thing here, is the fact that you have to assume everybody has it, and some people are higher risk than others. The next major concept is that of when the way to think about this whole epidemic, this whole problem, is basically what we want to do is treat everybody the way we've always treated them, with some minor exceptions, the biggest one being intramuscular epinephrine instead of nebulized treatments, but do it wearing proper PPE and being cautious. And then if there's a way to put a filter on something that is, somebody's exhaled air, put a filter on it. Other than that, we want to do everything the way we've done it before. And that makes this a whole lot easier to understand and a whole lot easier to deal with. And we have to understand that the personal protective equipment, PPE, properly worn, an N95, fit tested, and then seal tested right before use, is very effective at preventing healthcare providers from getting COVID infection. So is it perfect? Can I tell you for sure that if you do that, you're not going to have COVID infection? No. What I can tell you is the risk is quite low, but it's not zero. And there is definitely there is definitely some risk to participating in EMS activities during a pandemic like this, and that's just a plain cold hard fact. The next major point, the next major concept, Daniel cut me off if I'm getting long-winded, is the idea of a scout or sending somebody in to assess the situation. In other words, we're not changing our response, our responses to calls for emergency help. So you may get there and there may be a first response agency and a transport agency that gets assigned to a call. The first response agency gets there. They need to send somebody in an appropriate PPE for the call. So if it's high risk call, somebody's got a fever and a cough and shortness of breath, you put on your N95, you put on your eye protection, you put on your face shield, you put on your gown, you put on your gloves, and one person goes in and does an assessment to figure out what's needed. And then we use the minimum number of people to effect safe and effective care of that patient. We're not going to let our patients suffer here. None of us signed up to do a half blank job taking care of people. So we're going to take care of people just the same way we always have. However, we're going to do it with good, well-fitted personal protective equipment. We're going to do it with the minimum number of people necessary to take care of that patient. So this isn't the time to have 2 or 3 juniors on the call and some trainees and stuff. We need to sort of be as safe as possible so that as few people as possible are exposed, and that carries throughout the call. But I think if we all remember that basically we are treating people the same as we always have, we're just going to do it with proper personal protective equipment. We're going to minimize risk to ourselves and others. And if there's a way to put a filter on something that wasn't filtered before, we're going to put a filter on it. And that's kind of the big, broad overview that I think everybody should kind of understand. So I'll leave it there, and we can kind of go forward with more questions if needed.
All right, sounds good. Do you want to cover any, go through any of the other major changes? I'm certainly happy to do that as far as the document goes.
Why don't we stop for a second and see if anybody has any questions? Why don't we see if anybody has any questions just on the big picture issues, and then you can go through the documents sort of page by page and see if anybody has concerns or comments.
All right, the lines are open if you have any questions.
I have a question.
Go ahead.
My question is the reusing of the N95 mask. We were told that we could take the mask, put them into a brown paper bag, leave them for 3 days, and then reuse them. And then I was told a couple of days ago that we are not to reuse the N95 mask.
Okay, so the guidance to save the N95 in a paper bag is correct. We've not issued any guidance on reusing them 3 days later.
So in other words, get rid of them, throw them away?
No, I think it's a good idea to keep them because there may be a way in the future to recycle them. So save them for rainy day essentially.
I'm sorry, you kind of broke up. So save them and reuse them later, but get a new one each time we need one where we feel there's a coronavirus patient.
What's your name?
Debbie Young.
Okay, so I don't know why I haven't echo.
I'm sorry, what?
It's probably somebody's speaker on.
Could everybody mute their mics? Is there a way to mute everybody's mics?
Yeah, if you're not speaking, please mute your mic. Not sure if that's any better.
Let me try. Yeah, I don't know. This is bad.
I can hear you now, so.
Okay, let me try again. We are working on a way to recycle N95 masks. However, that process is not fully set up. And so if you save your N95 safely in a paper bag, in the future, we may be able to recycle them. It may be that we end up throwing them away. But if we throw them away now, we won't have a chance to recycle them in the future. But do not reuse your mask after just 3 days. That is poor advice.
Okay. Thank you.
You're welcome.
Debbie,
Sorry.
there's been some different information sent out on how long the virus can last on fabrics and different types of surfaces. The latest one I've seen is that it can last on a surgical mask up to 7 days. So pending the approval process, we'll need to be able to sanitize those. We just want you to see them.
Okay, I understand. Thank you.
I learned it from school.
It must be met before advancing each phase. And that's each phase specifically.
Miracle, get out of the bag.
Debbie? Debbie Young, can you hear me? Hello, Debbie Young.
Let me see if I can unmute her. I've got.
I thought she was maybe where the echo was coming from.
Okay, can you hear me now?
We hear you now.
Okay.
Okay, just be sure your mic is muted because I think when your mic's open, it's causing the echo.
Oh, it was muted. I had it muted, and I could hear somebody else's child talking. I don't have any children here. I'm by myself.
Oh, okay. I'm sorry.
It's okay.
Yeah, unfortunately, on my end, if I unmute the line, I can, it's going to cause everybody's lines to be open. So unless you're muting your own phone, we're going to have that echo with everybody's mics open. So the unfortunate part is if I mute everybody so that we can actually hear what somebody's saying, then you won't be able to ask any questions. So we really need you to mute your own line. We always end up with a lot of background noise. So the only other option I have at this point would be to submit your questions in the chat, or you can if you have an option to raise your hand, then you can do that as well.
Okay, so let me try again. So just to repeat that, the current guidance is everybody should save their N95 masks in a safe manner, which requires proper doffing. And then in the future, hopefully we'll be able to recycle them. But it may be that we end up throwing them away, but at least we'll have them to recycle if that time comes. It is not sound advice to reuse them after 3 days.
Yeah, you can, if you have a question and you're on the phone, you can press *6 to unmute. You can also send a request. I believe you have the option if you're online to send a request to unmute your line. So if there are any other questions, you can go ahead and submit those now, either via the chat or you can attempt to unmute your line and we'll see if we can get to everybody.
I have a question about nursing home facility.
All right, what's your name?
Bonnie.
Okay, go ahead.
We have a nursing home facility. They have pretty strict controls in place. When we go to pick up a patient there, they take her temperature and ask us the questions. Are we to do full gown, shield, everything, the nursing home also?
Yeah, so in the protocol, the latest update, we've designated basically patients of long-term care facilities are all high risk. It's to steal a phrase from Matt, it's like throwing flames into a box of matches. The protocol, the nursing homes, just because people live in such close quarters, that we're seeing once an outbreak starts in those facilities that it moves pretty quickly. So. And we'll probably see more of those. We already have some in this region, and you've probably all heard about the nursing home in Henrico County that has had quite a number of deaths. So yeah, you should use full PPE when you're going into those nursing homes.
Okay, thank you.
All right, any other questions?
This is Sherry. I had a question regarding, I know that I've read and I thought it was at one time in our protocol about shoe coverings, and you can actually track it from, with your shoe from one point to the other and then the back of the squad. Was that taken out, or is that per department discretion?
You want me to try that one, Daniel?
Yeah, go ahead.
I don't believe we've offered specific guidance on shoe coverings. I think it's certainly good practice to cover your shoes if you can. That is not PPE that we've really had access to. And so I think this represents one of the compromises that we've had to make, given the fact that the national stockpile is basically didn't have the PPE we needed in it. I do recommend, though, that people wash their clothes and clean their shoes after, after an EMS call. The main way that you get coronavirus, there are two ways, but the main way is somebody who coughs or coughs into their hand, touches an item, and then you come along and touch it, and then you get the virus on your hand, and then you touch your face. That accounts for the majority of the spread. The rest of the spread is by what's called droplet spread, and basically you can kind of picture it like when somebody's breathing or coughing. Imagine glitter coming out of their mouth, and so glitter has a little bit of weight, so it does settle down to the ground, but it might float in the air for a while.
I did.
Did you guys hear what I was saying, or?
Yes.
Okay. Did you hear the glitter when I was talking about glitter?
Yeah, that came across.
Okay.
Yes.
So think of the virus as glitter coming out of your mouth, and it can float in the air for a while, and nobody really knows how long. And there's been some stuff saying up to 3 hours, which is probably a little bit of an aberration, but certainly for a little while, these little micro droplets can kind of float in the air, and you could breathe them in directly and get virus from breathing in the air. But it's not an airborne infection like chickenpox or tuberculosis or measles. In other words, it's not going to float in the air for hours or go around the corner and down the hall and make a left turn through the air. So the virus is in droplets, and it drops to the ground fairly quickly. But if you're right in somebody's face and they cough or sneeze or breathe right on you, and you breathe in the air that they just breathed out, you certainly could get a load of virus. And so, if you're in a environment where somebody has a COVID infection and they're breathing on you, then yes, you can get virus on your clothes, on your shoes, and that would be an issue. Now, recall that every EMS patient that we have that doesn't have an advanced airway in has a mask on. And that alone is extremely powerful in terms of protecting us from getting an infection. And the patient has to worry about us giving them an infection, and that's why we all have masks on. And then the other thing we have in our guidance is that every ambulance and first responder agency should have alcohol-based gels to do hand decontamination. So you should decontaminate your patient's hands because that's another large repository for virus. So put a mask on the patient, decontaminate their hands. You wear a mask, you wear gloves. Be sure not to touch your face. Clean your clothes when you're done with a call. Clean your clothes when you go home. Don't, if you do wear your uniform home, take it off, wash it right away. Try to keep that away from your house. Get the shower when you get home from work or before you leave work. All those things can sort of reduce our risk. Is that helpful at all?
All right, we got comments that, yes, that was very helpful. Yeah, we've never actually had anything about shoe coverings in the protocol. And part of that is access, and part of that is, we, unlike the hospital environment, we're also moving to different environments. And so you can imagine that, as most of us wear oil resistant soled shoes, and, so we have some type of protective covering, whereas in a hospital, you might have tennis shoes, so you wouldn't have that kind of protection. But it's also pretty difficult to wear shoe coverings when you're trying to walk in exterior environments as well. Any other questions? Or comments? All right, so we sent out a post today with just kind of a summary of the highlights, or some of the major changes that we made. With the standoff assessment, we clarified a few items in here specific to the scouting process, as well as to the specific PPE. We added, as I mentioned earlier, residents of long-term care facilities and dialysis clinics as high-risk patients, as well as cardiac arrest. Limitations on personnel, we added some clarifying terminology to that, so that because we have heard from some agencies that there's still some confusion on how many patients should be engaging with, or how many providers should be engaging with the patient. And so we've clarified some of that a little bit to try to make it very clear what the expectations are. We also added a statement about homemade masks. Those would be for patients that are not exhibiting symptoms of COVID-19. And so we, if they have any symptoms, as we listed above, fever, cough, shortness of breath, or fatigue with flu-like symptoms, then those patients should have a surgical mask, and the providers should have an N95. For patients with no symptoms of COVID-19, providers should have surgical masks, and the patients would get a homemade mask or surgical mask if homemade masks aren't available. We've released, I believe 2 weeks ago, we released the updates on the drug box. We did make one minor change to that process, and that's that we want the form, the attestation form that's signed that you've decontaminated that box, to be placed in the handle of the drug box, not inside the box. If it's inside the box, then the pharmacy will not open it. They'll quarantine the box for 7 days. And we've had some issues with that. We'll quickly run out of drug boxes if we were to do that. We added some clarification, added back nebulized medications with medical control approval, and with proper PPE. And proper PPE is a properly fitted N95 respirator with a successful user seal test. And we emphasize properly fitted N95, meaning that you have to be fitted to that specific brand, size, and model of mask. If you've not been tested to the mask that you have, then you should not perform any aerosolizing procedures.
Can I jump in for a second, Daniel?
Yes, sir. Anytime.
All right. So the idea with the epi, and I think we might actually need to add some clarification to this part of the guidance, but the idea is that we're really not going to use nebs anymore during this crisis. There may be an occasional patient. Let's say you've got an 8-year-old kid who gets asthma when he runs, and he ran up the hill and he got asthma, and he hasn't been sick, and nobody in his family's sick, and there's no reason to think he's sick, and blah blah blah, and we just don't want to give him a shot of epi instead of a neb treatment, and then you can call medical control and get orders for that. Other than that, pretty much everybody that you think needs a bronchodilator should get IM epi. Because the nebulized treatments really do increase the risk of getting an infection from this stuff. And IM epi is a good bronchodilator. It actually works just as well as the neb. And so the idea is we're switching during this crisis from nebs to IM epi. If there's a rarity or some strange exception where, geez, it just doesn't make sense to do that, we really ought to use a neb in this patient. You have an out by calling medical control. And I think we might need to change some of the language on that to prevent confusion.
Okay. We added some clarification for BVM. We understand that not everybody has a bacterial viral HEPA filter, but if they are available, they need to be used. The same is true for CPAP. No changes to corticosteroids. We prefer you defer those unless you're treating another condition that's unrelated to COVID. For cardiac arrest, full PPE for all providers that are in close proximity to the patient. For CCR, we did change some of this. Perform chest compressions with an OPA and a non-rebreather covered with a surgical mask or an iGel with a HEPA filter. Endotracheal intubation is preferred for the intermediates and paramedics during CPR. And we recommended proceeding directly to endotracheal intubation after 6 minutes of compressions with CCR. So as you transition over to CPR, we should intubate those patients, preferably with a video laryngoscope and the most experienced provider. Anytime you're doing positive pressure ventilations, use a bacterial viral HEPA filter. Mechanical chest compressions as soon as possible, and that keeps the provider away from from being right over the mouth of the patient. And then when possible, do those chest compressions outside or in a well-ventilated area. If it's in the back of the ambulance, then that would be, with the fan on high. And so the other guidelines that we have down here below for aerosolizing procedures, the fan on high, vents open in the front if you don't have a way to isolate the cab from the patient compartment. We added some of that information in the transport section as well. If you are getting a refusal on the patient, you have patients with mild symptoms and they don't want to go to the hospital, we have links to the latest documents here. And instead of adding those documents, we just kept the link in here because the CDC changes those periodically, and that will ensure that you have the latest version of that. So whatever means you have to send that to the patient, whether it's by email or printed copy, then we just want to make sure they have that information, or at least know how to get to it. Transportation considerations. So we added some information, just some minor clarifications to this based on the documents from the American Heart Association and CDC that were updated and released last week. Minors and their guardians would be examples of people that would be transported with the patients. Otherwise, we should really try not to transport anybody with the patient. And one reason you might give to those family members who all want to go with the patient is that most of the hospitals are not allowing visitors to come into the facility. So they probably won't be allowed to go in with the patient anyway. Continue to work on preventing cross-contamination. And otherwise, documentation, we just want to make sure we're keeping good records. Also, make sure you're documenting PPE in your narrative as well as in your data fields. We are using that information on a regular basis at the Office of EMS to track PPE use, and we send that information then to the federal government in order to get priority on PPE distributions for the future. No major changes on the reporting structure. We did add another key points section here for first responders. If you're arriving before the ambulance, perform a standoff assessment, and initiate treatment of any potentially life-threatening emergencies. We don't want first responders arriving and then just standing there looking at a patient that's sick while waiting for the ambulance. Remember that you do have a legal duty to act. If you're arriving with the ambulance, then we should allow the EMS crew to assess the patient before everybody dons PPE and enters the scene. If you're not needed, they can then relieve you to go back into service. So we want to minimize patient contact with our providers. If arriving after the ambulance, check with the EMS crew before you go into the scene. And other than that, no major changes to the key points here. We did add the scan codes are still available, and then you can see the quick reference card here as well. Asher, do we want to address any of these questions below? For the people on the phone who wouldn't be able to see the questions from Amanda. First question was, can we wear Crocs on calls because they're easy to decontaminate?
I'm so sorry. Yeah, I didn't know what questions you were talking about. Go ahead, Daniel. I cut you off. I'm sorry.
Yeah, no, that's all right. The question was, can we wear Crocs on calls to make them easy to decontaminate?
Right, and I think the concern there is that we really need boots to protect our feet because we're not in a protected environment like a hospital. So I think when you clean the ambulance, that's really a good time to take some of that disinfectant that you use on the ambulance and spray your boots off and wipe your boots down at that point too. And there was an additional helpful comment that said, having Crocs immediately available in the ambulance bay is advisable so you can keep your boots outside of the common area. So maybe the Crocs could be used to sort of help keep things clean in the living quarters at the fire station or in the squad house.
That's a good point. All right, any other questions or comments? Would any of our infection control officers like to add anything to the discussion?
Hey, Ashley, you think it's probably a good idea maybe to let everyone know about, or remind everybody about the hospital for high flow oxygen?
I'm sure there's Augusta Health is concerned about people coming through the hallways who have high flow oxygen, and that would include patients on greater than 3 liters of oxygen. So if you have a patient on 4 liters of oxygen, 5 liters of oxygen, 6 liters, a non-rebreather, CPAP, BiPAP, any of that stuff, they don't want those patients coming through the hallways because they're worried about contamination. And so if you have a patient like that, I would make your call to the ER early to give them plenty of heads up time. And they should send a licensed healthcare provider, meaning an RN, nurse practitioner, physician's assistant, or physician out to see you, and they will likely reduce the oxygen level for transport through the hallways. But they will be assuming care of the patient, so you don't need to do that. You can do it at their direction, but it's clearly you document on your paperwork that you sign the care out to nurse whoever or doctor whoever, and then they asked you to turn the oxygen down. You can take them in and help them get unloaded and all that sort of stuff. If the patient's critically ill, and this is just Augusta Health, by the way, if the patient's critically ill, make sure they know that. Ask that a physician meet you in the bay to make the decision about whether or not to discontinue oxygen therapy. Occasionally, if the physicians are in a point where they can't get out, they might be busy with other resuscitations or upstairs on a cardiac arrest, but that should be pretty darn rare. And so certainly if there's a situation where you think you needed a doctor, or you waited a while for somebody to come out and meet you, or there are any problems at all, it's really important to let leadership know so that it can be addressed. Anyway, is that a fair overview?
Thank you, Ashley, for working on that. I really appreciate the outcome of, sure was better than when we started, so thank you again.
I think it's a reasonable compromise. We're all pretty concerned about taking oxygen off of patients that need it. So, please, anybody with concerns about an individual case, raise the flag, let us know. We'll take a look at it and try to improve the process if we need to.
Thank you, and thank you, Kim, for bringing that up. I had that on my minimized screen there to bring up, but I did almost forget about it. Amanda had another question. Are we going to pursue alternate transport destinations?
What are we calling it? Surge and then crisis? Is that right, Daniel? Surge and crisis? Yes. I'm not sure what our nomenclature is, but if we get in a situation, and fortunately the current predictions are that because of effective social distancing and people doing the job they're supposed to do about staying at home, it looks like we're not going to get overrun here. But if we do start to get overrun, we have surge plans that we will roll out kind of on a as needed basis to say, hey, this is how we're going to change our operations. And then we'll also have crisis plans that we'll roll out sort of in a just-in-time basis in the situation where we're totally getting overrun. And certainly in the surge planning, that will include transport to alternate facilities such as urgent cares, pulmonary assessment centers, possibly even doctor's offices. It will also, depending on the circumstances, include triage of 911 calls, stacking of 911 calls, and denial of EMS responses for certain types of calls. But those are all will be based upon our system getting stressed to various degrees, either what we call surge or what we call crisis.
And I'll add on to that a little bit. So you probably know that CMS released some guidance relaxing some of the restrictions on where patients could be transported. And so now agencies can bill for transport to appropriate alternate facilities. However, that doesn't mean that we utilize a crisis to completely change the way we operate. And it may be in the future that we will look at the opportunity to transport patients to other places other than the ER. But this isn't necessarily the time to take advantage of that. So the Office of EMS released a white paper late last week outlining some of the directives. There's currently not a regulation that says you can't transport patients in Virginia to other destinations. However, if you're going to transport patients, for example, to an urgent care or a physician's office, there has to be an agreement with that agency, between the agency and that destination facility that acknowledges that they're willing to take ambulance patients. It wouldn't be a good patient practice to take patients that are, especially if they have critical conditions, to start transporting those patients to a primary care office and just dropping them off without some type of agreement in place. They may not have the capacity to see that patient, and they may not have the space to see them. So So we can't just use that as a blanket authorization to transport patients elsewhere. So that has to be done in conjunction with a very specific protocol approved by your agency's medical director, and with a written agreement in place between the agency and those destination facilities before alternate transport destinations can be established. The other alternative to that is that, as is being done with some of our hospitals now, is that a hospital can specifically designate centers as alternative locations to their ER based on their surge planning. And I know that's going on, to my knowledge, in pretty much every hospital in our region, that they're at least discussing those opportunities as to where they would transport patients as an alternative. Does that answer your question? And I just got a question by email. Can we get the virus from your mail?
Virus is not particularly hardy. Like it lives in droplets. It requires moisture. It's a protein. And so if it dries out, it kind of dies and doesn't become, pathogenic, or it doesn't pose a threat to you. There have been some studies that have suggested the virus can live up to a couple days on substances for a while. Whether or not they survive in numbers enough to get you sick is unclear. Really, the way you get this is somebody coughs near you or in your face, or somebody coughs in their hand, opens the door, and then you go through, 3 minutes later, and then you touch your face and get it. That's the main way that this stuff gets transmitted. That said, and without any science, and this is just my opinion, if you take the mail, if you're kind of careful with it, or if you get a box from Amazon or whatever, and you just let it sit for a few days, 3 or 4 days, before you open it, maybe you spray it down with something a little bit and then open it, I think you're about as safe as you can be. There's no science on it. That's just an off the cuff. That's what we do. So I hope that's helpful, but please understand that's not based on any kind of research or science or best practices. That's just kind of my advice.
I would agree. The risk is low, and mainly wash your hands. Open the package, wash your hands. Don't lick your fingers off after you open all your mail. And you should be in pretty good shape. Any other questions? It appears we've answered them all. I'd like to thank everybody for joining in. If nobody else has any other comments, Asher, do you have anything you want to close?
No, thank you for joining, and we are open to having conference calls with specific agencies. If you have individual providers that are having a hard time with this crisis, please reach out to us. We want to help as best we can, and it doesn't matter who you are, what you are, where you are. If we can help, let us know. And I think information is the greatest weapon we have against this infection. So thanks for attending this call.
Thank you.